Assalamu alaikum and good evening to everyone, respected chairperson, respected judges and everyone gathered here today. I apologize amongst all the amazing clinical cases if my intervention case will seem rather mundane. I'm Dr. Nazmun from the Department of Cardiology at the National Heart Foundation Hospital and Research Institute. My case is a 60-year-old gentleman who's hypertensive and a smoker. He presented with chronic coronary syndrome with gradually worsening angina, CCS grade 3. However, his electrocardiogram was normal. He had a preserved LV systolic function. So we went to do his coronary angiogram, and you can appreciate that left main coronary artery has a 50% stenosis involving the origin of both LAD and circ. LAD has a tandem lesion with a 90 to 95% stenosis at its proximal segment starting from the origin and a 70 to 75% lesion in its mid-segment. Circ had a soft plaque of about 60 to 70% stenosis in its proximal segment, again starting from the origin. And the right coronary artery is the dominant artery and free of significant disease. So the syntax score of this patient was 23, and we offered him CABG and PCI. However, when consulting the patient and the attendants, they wanted to go forward for a PCI. So we took a 3.57 French EBU catheter and wired both the vessels with our floppy run-through wire, which is our workhorse wire at our hospital. And we did the IVUS study, and you can appreciate this diffuse calcification almost in certain areas involving the left main and the LAD. In certain areas, there is 270-degree calcium with failure to penetration of the ultrasonic waves beyond the calcium. And L-circ ostium had a plaque as well. So for such a calcified lesion, it's so important that we prepare the vessel bed properly so that we have good expansion of the stents that will be implanted soon after. So to improve the vessel compliance after modifying the calcium. So we went to use a 3 by 15 millimeter scoring balloon, and this was inflated to 14 and later 16 atmospheres. Then a 3.5 by 38 millimeter drug-eluting stent was placed from the left main coronary artery to the LAD and was deployed at 10 atmospheres. The stent balloon was pulled back and again inflated to higher pressure at 16 atmospheres. After this, you can appreciate that there's a bit of a plaque shift involving the circ origin and extending into the OM. Because of this, we did a pot in the proximal segment of the left main LAD with a larger balloon, 4 by 8 millimeter non-compliant balloon, and with this was deployed. This was inflated to very high pressure of 20 atmospheres, and then we went to stent the mid-LAD lesion with a 2.75 by 38 millimeter drug-eluting stent, overlapping with the first stent, and deployed it at 8 millimeters. Following this, the circ was rewired through the distal strut. And because there was this, plaque shift, we decided to use a small short balloon, a 2 by 12 millimeter balloon, and inflate it to 8 atmospheres to see if any balloon angioplasty would help without stenting the side branch. But however, there was still a bit of I'm sorry, my slides aren't moving. Because there's still a significant amount of plaque in the circ, so we decided to do a stenting of the circ, and because of the wide angle, more than 70, and considering the caliber of both the main vessel and the side branch, we opted for tap technique as the double stent strategy in this case. So we placed a 3.5 by 12 millimeter and we commonly do a balloon-assisted tap in our hospital. So we placed a 3.5 by 12 millimeter non-compliant balloon, kept it at the LAD, and placed a 2.75 by 12 millimeter drug-eluting stent at the circ, covering the circ origin. And we inflated the LAD balloon to 4 to 6 atmospheres, pulled back the stent as much as we could, and deployed it at 10 atmospheres. And after deployment, the stent balloon at the circ was pulled back further, inflated to higher pressure, and then a kissing balloon inflation was done with the stent balloon at 14 to 16 atmospheres. We went on further to do another kissing inflation with a 3.5 by 12 millimeter non-compliant balloon in the LAD, parked at the LAD, and another 3 by 8 millimeter non-compliant balloon at the LCX, and we did a sequential kissing followed by simultaneous kissing at 14 atmosphere. Finally, a report was done with a 5 by 8 millimeter non-compliant balloon, and this was the IVUS study afterwards, and you can appreciate that there's good apposition of the stent struts without any obvious dissection, and this was our final angiographic views. So in conclusion, a provisional stepwise layered approach is the standard for treatment of majority of bifurcation lesion, and it is all the more important in case of left main disease, because the more simple we leave it, the better the outcome. And we must always respect the original bifurcation anatomy and try to reproduce it as much as possible. And this is where proximal optimization and kissing balloon inflation is of utmost importance. Using of imaging modalities like IVUS for choosing the appropriate sizing of the stents for the side branch assessment and stent deployment and stent optimization is crucial. From the entire cath lab team at our hospital at National Heart Foundation, thank you very much for your patience, and thank you for allowing me to present at this podium.